Obviously, the greatest conversation was about the plenary abstract, which was ADAURA. And one of the abstracts I covered, the CTONG adjuvant study, helps put that into context. So we're talking about patients with stage 1B to 3A, EGFR mutation positive non-small cell lung cancer who are candidates for a curative surgical resection. The backdrop of this, of course, is that surgery doesn't work nearly as well as we'd like it to be. On a gross basis, about half of our patients that we treat with curative intent will recur, obviously with that risk rising by stage. We typically give 4 cycles of adjuvant chemotherapy to patients with node-positive cancer, but unfortunately the survival advantage is only 5% at 5 years, creating a massive unneed for better therapies. The ADAURA study took patients with 1B to 3A EGFR mutated non-small cell lung cancer who had gotten standard of care therapy. So surgery, and if they wanted it, adjuvant chemotherapy. Interestingly, only half got adjuvant chemotherapy. Though I'm sure there'll be a lot of conversation about that. But at any rate, at the end of that standard of care therapy, they were randomized to either 3 years of osimertinib or to placebo with a primary endpoint of DFS in the subpopulation of patients with stage 2 or 3A disease, which is the population in which there's no controversy that adjuvant therapy is indicated. That DFS advantage was massive. It was a hazard ratio of 0.17. That's extraordinary because if you look to the close to historic precedent, there was a study once called Saturn that is an interesting starting place to start thinking about this result. So Saturn took patients with stage 4 lung cancer, right? Incurable active disease in every patient who had non-progression after 4 cycles of chemotherapy and randomized them to maintenance or erlotinib or placebo. And if you look at the subgroup analysis of the patients who had EGFR mutation, the hazard ratio there was 0.16, almost the same hazard ratio, even though in this study, half of these patients have no disease to be treated, right? They're curative intent patients. So that speaks to the efficacy of osimertinib as a TKI. For DFS, this is just a massive advantage. And where the curve started to lose maturity around 2 or 3 years, the curves were still quite well separated with no hint of convergence. That point about convergence is really important because that's what's happened in all of the prior studies of adjuvant TKI, such as the CTONG study that I discussed in Best of the Day, that there's a big DFS advantage early on. And then in the case of the first generation studies, a year and change after you've stopped the TKI, the curves converge, and there's no advantage in survival and certainly no advantage in cure. And so the question with this data is this going to be different? Or is it going to be the same story repeated over again? On the optimistic side of thinking this could be different, osimertinib is a more potent, more effective TKI than the first generation drugs, not by a small amount in the stage 4 setting. And it's less toxic. Not toxicity free, but less toxic. And so if there were to be a difference in survival in this study compared to others, that greater potency and lesser toxicity would be where you would hope it would come from. And the clinical data thus far, for those who want to be enthusiastic, gives reason for that. The argument against is what's happened with all of the prior studies. The extent to which we learn this is controversial right now. This is a very controversial study in the Twitter sphere and then the sphere of texting internationally and email internationally. There are some who are very enthusiastic and others who are not only skeptical about whether this will turn into a survival advantage, but even skeptical about whether the early unblinding and the way the study was designed, where it was done, whether we'll ever really find out that answer.